I have I think a really positive message. So it's been a great tragedy these last 2 years, but it really didn't have to be that way. We've really, I would say with my esteemed colleagues here, thank you for all of you have sort of influenced a lot of my thinking. And I think all of us will say that we have this. We know how to treat diseases. So COVID-19, the novel coronavirus, right from the get-go, I spent 9 years in a tissue culture lab doing inflammation scarring, tumor virus work. I really just looked at it, okay, it's a respiratory virus. What do we know about respiratory viruses? We know that respiratory viruses live about 5 to 7 days. So I was, as I looked at this, I thought, well, that's probably going to be true for this virus. We didn't have it cultured yet, but as it turned out, in the first year of culturing the virus, I don't think any live virus was cultured past 8 days. It was usually about 5, 6 days. So that held true. So back in March of 2020, a bunch of my colleagues, we assembled, we started looking at options of what we can do. And it became quite evident after talking to people in Italy and South Korea and elsewhere that it was a respiratory virus that was going to be causing a lot of inflammation. And then one of the unique things that was happening here, this respiratory virus for a coronavirus was causing a lot of blood clotting. So you had respiratory distress, blood clotting, and inflammation. And so as a physician, those are easy conditions to treat. The difficult part was really attacking the virus. And at the time that I first looked, again in March, early March 2020, I found about 8 things that might work based on mechanisms. And so I think these are, like, in a sense, tools in the toolbox that we ought to be trying. So my first patient, I treated with hydroxychloroquine, erythromycin, vitamin D, aspirin, and steroids. And I literally was shocked when I went and talked about it that that people were really coming at me about the steroids, because anybody who treats respiratory syncytial virus and other viruses, the inflammatory phase is typically one of the most important phases. And of course, when Dr. Corey came out and said that, he was attacked mercilessly too. But to anybody who treats disease, it really, to me, I was kind of surprised to get attacked. I was getting attacked by people who really didn't know what they were talking about. So what I'll say is, as people who are listening, it's an inflammatory disease. It's a blood clotting disease. We have lots of medicines for inflammation. Why would you not treat inflammation as an outpatient? We have so many different drugs. Why would you not treat blood clotting? We have who gets admitted to the hospital for blood clotting? Maybe a day or two, and then you go back out. There's lots of things we have. Attacking the virus, you have to do that in the first week. And what has happened? We actually have drugs like remdesivir, which are being applied day 15 and 20. They have no chance of working. It's a one-trick pony. It has to work when the virus is replicating. So at that point, what I tell people is the problem is these drugs are, viruses and cancer cells are unique. They use our own machinery. So if you're not killing the virus, you're killing something. You're killing our mitochondria, you're killing our cells. So these are just strategies that it doesn't take a lot of thinking. As a physician, I literally am shocked to see people using these drugs, 2 and 3 and 4 and 5 weeks later. They can't work. So at the end of the day, I think the message that I kind of want to send is, as Dr. Cole said earlier, the virus isn't killing people. It's, in a sense, it's the viral particles creating the inflammation, creating the blood clots, the cars versus the car parts. So it's not dying from the cars, you're dying from the car parts. And we've had this the whole time, and I want to make one more, which I think is an important point. I would tell everybody, you can take any 2 drugs away, hydroxychloroquine, ivermectin, and still save almost all the lives. And that's the end message. We have so many tools in the toolbox. That's the message I want everybody to hear. We can beat this disease. I'll give you one more caveat. As we went from Delta to Omicron, one of the things that happened, and we all we worked together as a team in a sense, we recognized that Omicron did not employ TMPRSS2 binding. What that means, it's like, in a sense, the virus grabs onto cells and it uses an ACE2 receptor, and it also uses another receptor called TMPRSS2. It's a serine protease. The bottom line is we realized that a lot of the drugs that we were using for Delta, we didn't need in this new disease. That's called the practice of medicine. We adjust. That's what we do. That's how we've always done it. And that's why an ophthalmologist can figure this out, because I had a big background in clinical medicine. I've treated over my career over 300,000 patients. And I'm going to say that I think what you found here, which I want to answer the last point that that Senator Johnson made, is why is an ophthalmologist treating? Because patients were languishing at home. And I've treated over 1,600 patients because patients were languishing at home with no treatment for inflammation, with no treatment for respiratory distress, with no treatment for blood clotting. It's absolutely absurd, and I wasn't going to let it happen. And I think, as you see in this room, all of us feel the same. Thank you.
Well, thank you, Dr. Urso. I'm going to break protocol here because I'm in charge. Because there's another question I have. And this is the $64,000 question, and I'll have all of you answer it in some way, shape, or form. Why aren't other doctors using their medical skill? Why aren't they practicing medicine? Listen, I think it's appropriate to practice protocols. I mean, you're developing protocols and you're practicing them, but why haven't more doctors thought outside the box and, again, had the courage and compassion to actually treat patients as opposed to follow the compassionless guideline from NIH, just succinctly?
So, succinctly, this. When we first came down in March, we were getting messages to go home. And some of those messages were really strong. They basically said, and this is the start, the fear came into doctors' hearts. They said in Texas, for instance, if you used PPE, that you might be criminally liable for interfering with an Emergency Use Act. And it was pretty scary. A lot of us were like, well, what are we going to do? And we're like, well, I guess I won't wear a mask. But that only continued. It was a coordinated attack creating fear, and doctors felt that. And many doctors are actually working in employed positions, and as time went on, they were told in no uncertain terms, if you use these drugs, you probably will be fired. And nobody had to tell them. They're smart people. You don't have to draw a map. I want to personally thank you. In the past, medical schools and conferences like this would take place. We debate how to treat these kind of diseases. And, it's kind of strange that this meeting has to take place in the U.S. Senate. Given the current state of affairs, that's where we are. But in the past, we would think that somehow the FDA, the CDC, the NIH, we would have basically maybe a message board, exchange ideas. And I really want to reach out and say thank you for what you've done to Dr. McCullough and Dr. Risch, who initially set all of this up. The extreme censorships and attacks have led us to come to this place. And so I want to just thank you for what you've done. You've really pushed this all forward, you've been yourself become a researcher and a scientist over this last 2 years, so thank you very much.
I appreciate that.
Your question sort of begs the answer to, does asymptomatic transmission occur? That's basically what you're saying. You were asymptomatic at the time? Okay. So that has never been the driver of a pandemic or an epidemic of any kind. Asymptomatic transmission has been used during this pandemic to create fear over and over. Asymptomatic transmission, if you look at the studies that have been done, I think there's like 7 or so, basically asymptomatic transmission is responsible for less than 1% of cases. What you do see in people who are asymptomatic, quote unquote, is when they convalesce at home, an interesting phenomenon sometimes occurs where the other family members and other close contacts also become asymptomatically, in a sense, they convert their T cells, and you can measure their immunity. But my point is that asymptomatic people, and I think this has been a fear for many in this country, that asymptomatic transmission is occurring. And so I think the answer to that is it is not a driver of this pandemic, and it's been a driver of fear. And I think it's important to let that be known. Masks have been looked at for 3 decades or so, where there's been randomized controlled trials. So there's roughly, 12 or so randomized controlled trials. There's 0 randomized controlled trials that show masks stop the spread of respiratory disease. And that's including N95. And for everyone, N stands for non-oil resistant, 95 stands for 95% airborne particles, of which all viruses fit through. So I usually tell people that, wearing an N95 also has not been shown in randomized controlled trials to be effective. But more importantly, the capsule on these viruses are an oil capsule, and I tell people it's like peeing in a pool. It goes right through. It doesn't stick to water molecules. It's an oil capsule virus. At the end of the day, the data is what it is. There's zero randomized controlled trials at all showing that mask stops better upper respiratory disease.
So
I want to kind of go off what Dr. McCullough said. Really, we're looking at the risk, but the question begs the risk-benefit ratio. That's really what we're getting at. Is there a risk for these low ivermectin, hydroxychloroquine? I always tell people, yeah, hydroxychloroquine's got so many side effects, like Dr. Parks talked about. Lowers the cholesterol, lowers the hemoglobin A1C, lowers the glucose, lowers the insulin resistance, lowers D-dimer, C-reactive protein, sed rate, decreases stroke, heart attack, pulmonary embolus, decreases chronic kidney disease. So there are a lot of side effects associated with these drugs. So that's one. I don't want to finish.
He's being very
now
facetious. Those are all benefits.
There are now 96 clinical trials going on at clinicaltrials.gov for use of hydroxychloroquine in cancer, so solid tumors. So if you go to clinicaltrials.gov, that's where you're going to see. So these drugs have a lot of side effects. They're really, for the most part, wonder drugs, and they can cause side effects. Jokingly, I was being facetious earlier, but they can cause GI side effects.
You really need to point out how facetious you were being. I mean,
okay, all right.
No, I'm dead serious about that. I mean,
in case you didn't know, lowering the glucose and lowering the rate of stroke and heart attack is a good thing.
those are benefits, not side effects.
The bottom line is that many of the drugs, like azithromycin, have wonderful effects on so many levels, on inflammation, on viruses, on many things that I've been using for 20 years for scarring. So if you look at what we're prescribing and you talk about the risk-benefit ratios, what we are prescribing is very, very low-risk drugs over and over. And you can compare those, the ones that have been developed by Pfizer and Merck. One's a molnupiravir, which is a nucleoside analog, and I want to go into this because I think it's important. These are not creative thoughts. These are old drugs from the 1950s that have been dressed up and put back out there, and they are going to kill viruses because viruses use the same machinery we do, but they'll also kill your mitochondria, they'll also kill your normal cells. They're actually not too bad at killing cancer cells, anything replicating quickly. So we are seeing the use of Paxlovid, which is like a Kaletra 2.0. So we are seeing drugs sort of being dressed up and repurposed. They are repurposing themselves and putting a price tag on them. They are using repurposed drugs with a higher price tag. Everyone needs to know that.
They get to repatent them.
In their own way. So that is one of the issues with what we are seeing. These are not creative things. Remdesivir, that is not creative. Neither is molnupiravir. I cannot say that enough. It is not a creative thing. The drugs we are talking about are wonder drugs. They really are. Ivermectin, hydroxychloroquine, azithromycin, cyproheptadine, Pepcid. There's a whole list. I've got I won't go through them, but there's a lot of things we can use. They're incredibly safe. And you can save lives. We've had people save lives without hydroxychloroquine, ivermectin. There's a doctor from South Africa named Dr. Shetty, we all know. He saved over 7,000 people without using any of those drugs. I don't think people realize that all these people who had COVID were excluded from the trials, all of them. Yes. So we're going to take our 5 to 11-year-olds, that there's 28 million. That means 14, it was about half and half. It's probably more, 60% have had COVID already. So let's say 12 million have not had COVID. So if those 12 million had the vaccine and it was a perfect vaccine, it's 0.1 per 100,000, we might save 12 children. What's going to happen to the 16 million children who've already had the virus, who already have immunity, and we're going to subject them to something that wasn't even tested in that group? It's literally absurd. And that's the thing I would say, Senator, is that we're not here about civil liberties and mandates. We're here to save lives. And this group of people should be excluded, absolutely. There's an Achilles heel to the program of natural immunity. Natural immunity denial should not be happening. It should be a major focus of what we're trying to do here, because you're going to harm, I don't know how many children by force vaccinating 16 million children. It's absurd. We knew early on. We had treatment early on from the very first day in March.
Yes.
That's a fabricated lie. It's scientific fraud to say that. There was treatment for inflammation. There was treatment for blood clotting. There was even treatment that we could try for the virus. There's treatment for respiratory demise. It was definitely options.
But again.
And so as we went on, as he just talked, and I don't want to interrupt, but just let me kind of cover on this. The virus, respiratory viruses are gone in 5 to 7 days. To say that this corpse could contain this respiratory virus a month or two later is ridiculous. So it's been a fraud from the beginning, and I don't understand why, but to go to just one more quick thing, the NIH, the CDC, and the FDA are not involved in medical education. We went through a residency, a medical school, a residency program. We have colleagues, mentors, people that we rely on. I've seen 300,000 patients. I've never called the FDA, the NIH, or the CDC one time for advice. It's not who we call. So to have them dictate our medical practices has to stop. It should not ever have been done. We've got to find a way to fight back. The public knows that hospitals are dangerous places, like Dr. Merrick said, and we've got to reinvent the wheel, basically, because our current system is the corporate practice of medicine telling doctors what to do when we already know what to do. There's a nuance, and we know it. Each and every patient has a slight potential thing that we might do differently. And if we don't do that, we are not good doctors.
Again, so what I want to know is this completely a new phenomenon where the federal health agencies are really dictating how doctors, or was this a slow creep?
So historically,
to
just
that?
a quick history. I'll let Pierre talk, but the quick history is, historically, I was very closely aligned with the hospitals, and it was more like hospitals and doctors were, the CEO of 2 major hospital systems were very good friends of mine in Houston. One was my next door neighbor, and one was a good friend from medical school. Bottom line is, we were with the hospitals. It felt like a partnership, and we kind of felt like the insurers were the other side of things, like we were kind of us against them. But the hospitals started pooling together, they started building these big organizations, and now they are the most powerful entity in medical care for us. And so we have to deal with them.
Again, so it's,
Yes.
Paper by Jiang and May,
Yes.
where it goes into this data. SARS-CoV-2 spike impairs DNA damage repair. Yeah,
Okay,
I want to ask Dr. Malone that question, because
I would
I
like
worked with lipid nanoparticles for chemotherapy. They are like garlic. They go everywhere. They can, they can slip through a door crack. They go through very tight junctions. That's what they do. That's why when I first saw the technology, I knew it was going to end up in the brain, because that's one of the things they were doing, was trying to find lipid nanoparticles to carry chemotherapeutic
talk about
agents.
the concern about it getting into the brain.
Well, that was the actual original design for lipid nanoparticles, to be used in chemotherapy, because in order to direct chemotherapy to the brain, it's very difficult. So they were going to use lipid nanoparticles to do it. The problem was the lipid nanoparticles went into ovaries, bone marrow, adrenal glands, and other tissues. So it's still being worked on. Studies are still being done. But I was going to ask Dr. Malone, because Dr. McCullough had just talked about the fact that he has concerns. Do you have concerns for this vaccine in children, knowing that it's going in the brain, the bone marrow, the adrenals, and all these other organs?